Greetings from Europe. We are very... yeah. So I'm very glad that you still like to cooperate with Europeans. So my lessons are not from Germany, but from the German-speaking countries, because our intergroup, or our group, is German, Austrian, and Swiss when it started. Sandra asked me to give a little history of COSS, Cooperative Osteosarcoma Study Group. I would like to go back in history so that you understand why we are working the way we are working. This is England in around 700 or so, 800. A few kingdoms, a bit later, one United Kingdom, politically centralized, healthcare, meanwhile also centralized. This is part of the Holy Roman Empire after the 30-year War. And you see there's not much centralization because every different color represents a different independent country. Yeah? This is Germany today. We have 16 federal states, independent more or less, or somewhat independent. Healthcare is not a federal issue. Healthcare is a state issue, yeah? State jurisdiction. Centralization is absolutely not a priority of the states. And so we have more than 45 pediatric units who treat children with cancer. And that's the situation we have to deal with. It's a different situation from the one you have. How did our German Society of Pediatric Oncology and Hematology tackle this situation? We formed study groups, or our predecessors in the early 80s, late 70s, early 80s, formed study groups under the roof of the GPOH for every single pediatric malignancies. Of course, we have interdisciplinary cooperation, but that also allows for multi-centric cooperation. These study groups have two broad aims. One is science. Like every study group, there's some sort of science, clinical or otherwise, but also quality assurance of treatment for children who are treated for cancer in Germany. The quality assurance is assured by multidisciplinary protocols, even when there's no trial available, where the diagnostic and therapy standards are laid out, supportive care standards more or less also. We have central review for pathology for every child, and radiology review is also offered. And there is a system for expert consultation. So I'm the chair, for example, for osteosarcoma. If there's anyone anywhere in Germany who has a question about anything in osteosarcoma, they address that question to us in Stuttgart, and we have an expert panel which we can rely on. Thoracic surgeons, orthopedic surgeons, radiologists, nuclear medicine, you name it. We have this panel, we discuss things, we give recommendations on everything, local, systemic treatment, chemotherapy. This quality assurance issue is somewhat mandatory now because there's a national regulation which forces pediatric oncology institutions to offer participation in this system to all parents of all children. So we have to offer that. It doesn't matter which institution treats the child. Here's all the groups. So this is German, all the different tumor types, and there are different groups. So we have, for bone tumors, of course, the KESS or Euro-Ewing group and the COSS or Euromas group for osteos. This collaboration has led to an improvement in results. This is just 2-year survival because in the 40s they didn't have anything else. And for every disease it moved up. Osteosarcoma is the green line. Which one here, I think? It's here, this one. Not that much improvement recently. So that's the background. Now to our group, Cooperative Osteosarcoma Study Group, COSS. started out survival rates with surgery only. This is from an old publication from the mid-70s, and by the time the first person was landing on the moon, this was survival at 3 years, somewhere between 10 and 15%. Then the first results or first reports of successful chemotherapy came out: methotrexate, doxorubicin, later, a little bit later cisplatin, then ifosfamide. Then combination chemotherapy reports came out in the mid-70s. And at that time in Germany or in the German-speaking world, there were 2 hospitals which pioneered this. One was Hamburg under the lead of Kurt Winkler, my first mentor. And in Austria, Rainer Kotz, he's an orthopedic surgeon in Vienna who also published on combination chemotherapy in 1977. Then the 2 groups got together, the Vienna and Hamburg group with many others, and formed the Cooperative Osteosarcoma Study Group. And from the beginning, there was pediatric and adult oncology involved, and all the other disciplines got together. So it's not a pediatric oncology group, it's an interdisciplinary group. First protocol, methotrexate, doxorubicin, at the time cyclophosphamide, and this is what was published. See, different computer types at the time. But at 4 years, overall survival somewhat around 50%, except for these 71 patients who were published. We went back last year and found 72 of the 71 in our database. For some reason, there was one more. And this is the long-term outcome. We have a median follow-up of 11 years for those patients, and about half of them became long-term survivors. So decent. The strategy changed a little bit in 1980 when part of the chemotherapy was moved before surgery, so a neoadjuvant approach. The drugs which we've used have been the same as the drugs which everyone else has been using. 3 standard drugs, some protocols included ifosfamide, some protocols others. And now looking at the background studies. We have our COSS studies, like the Euroma study in which we participated. We register selected patients into clinical trials. Everything is according to protocol. Of course, we started with Germany, Austria, Switzerland. Then we went into this intergroup, intercontinental collaboration. And of course, we experienced the change from permissive oversight to protectionist oversight, which we have now, which makes everything a lot more complicated. Jeremy has shown you the European and American osteosarcoma study experience. COSS, we were able to recruit 520 patients, mostly from Germany, but also from Switzerland, Austria, and later on from Hungary and the Czech Republic. What else have we learned? Maybe I didn't know what Jeremy was going to say, so I thought some other messages which I thought were important. I think it helps to keep investigators and their teams motivated. So at the time we had funding available to run training courses, have meetings. That was very helpful. We learned that the strong intergroup has a stronger lobbying power, so we were at the time lobbying for changes in the EU clinical trials directive. We got exposure in the Lancet Oncology. We got invited to consensus conferences which were organized by the European Union. So I think maybe we had a little influence there. We learned that we needed to have clearly defined responsibilities with timelines, because when we didn't really move forward. We needed constant communication, and we also learned from each other about the different environments, and that things which might work for one country in one healthcare system would not work the same way somewhere else, or for the whole intergroup. And what we also sadly learned is what Jeremy has so elegantly shown us, that just because things work the first time around, it doesn't mean it will automatically work out again. Yeah, why did Yermos work? There's many reasons, and I think the most important one is friendship and trust among the key people. And if you don't have that, don't start intergroup collaboration. If you have it, you can. And then now, if we look at clinical trials, we're faced with good clinical practice regulation. As you all know, good clinical practice has nothing to do with being a good clinician, but it's a legal framework which was developed for commercial drug development, and it's the death of all sound work. Okay, that's the clinical trials. Now, the registry. During all those years, we have always recruited all patients with osteosarcomas or, let's say, similar diseases, what used to be called MFH now, differentiated pleomorphic sarcoma of bone, leiomyosarcoma, even dedifferentiated chondros. We've all recruited those into our registry. We try to have indefinite follow-up. This is the basis, the population from which we draw the patients for our studies. We can also perform scientific analyses independent of the studies. And of course, we have this free expert consultation system. Again, Germany, Austria, Switzerland, some patients from, or some centers from Hungary and the Czech Republic joined more recently. When we look at the high-grade central osteosarcoma patients who are registered at first manifestation, in this time period, I have those slides available. This is what we registered per decade, so above 1,000 patients per decade from these centers. So you need many partners to do that. This is the COSS 77 3-year period. This is room 1 of the next 6-year period. So a lot of information coming in. We always have about 1/3 of patients who are registered by non-pediatric units, and correspondingly almost 1/3 of patients are above the age of 18. The number of non-extremity osteosarcomas has been rising, probably because of all the medical oncologists who contribute. Proportion of osteosarcomas registered as second cancers has been, or secondary cancers has been rising. And we have a clear stage of migration, which makes it a bit difficult to compare some things across the ages. We started out with about 10% patients with primary metastases and a few where you didn't really know. Nowadays we have about 20% of patients who are registered as having primary metastases and about 10% where you have something but you don't know what it is. Surgical procedures have changed. Amputation, rotation plasties have really gone down. Nowadays, most patients have limb salvage surgery. Whether it's always a good idea in a young child could be a long discussion, but that's the reality. Here's the follow-up which we have. Of course, in the first year, everyone has a follow-up, and then you go down. The red ones are the ones where we haven't heard that they have died, but we haven't heard of them in that year. And so our median follow-up is somewhere above 10 years. And this is the overall survival probability for all comers, around 60% at 15 years. But of course, if you look at the trials, you see something else, and that's because the trials usually have the localized limb osteosarcomas and the others are all out. We have the information on those. I think it's important information. Yeah. And you see for the first decade now we're at above, at almost 20 years median follow-up, which is quite good. We haven't really improved things for the past 30 years. Yeah, it's always same results. Now, is this registry just for fun, just so that we are doing something, or is someone interested in the results? I think the results, people are interested in the results. Here in red, I've looked at Google Scholar asking which papers had the most, which COSS patient papers or papers to which we contributed had the most, were the most highly referenced. In yellow, you see registry papers, which we did ourselves. In green, registry papers where collaborators from other COSS institutions came and did analyses on our data. And you see that the green and yellow dots by far outnumber the red ones. So people are quite interested in the results from the registry, even more than in the results from our studies. So if you want to find honor and glory, do COSS registry analyses, and we invite you to send us your proposals. Yes, now Sandra asked that I should talk about funding. Which money do we have to do all this? Quality assurance, the quality assurance bit is good. Because of this national regulation, we receive some money for the expert consultation, which we can spread around. It's not millions, it's about 100,000 per year for all of us. So it's something. Science. The funding organizations, the science funding organizations, they only fund projects. They don't fund our infrastructure. So our infrastructure has zero infrastructure funding. Charities, support by charities, it's very heterogeneous. Some have project funding, some just want to be nice and give you limited amounts of money without really specifying what it's for. And that's quite important, especially our regional parents organization without whom we couldn't do what we're doing. And here's the funders who have funded us. German Cancer Aid, big public science funding organization, the state or government funding organization, Deutsche Forschungsgemeinschaft. We had money from the European Science Foundation for Euromos. Very, very complicated, but we did get some money and some money from others. And the parents' organizations and a small charity which is supporting us on a regular basis. We have not yet received funds from this maker of cheap Chinese watches. This was bought in London, you know, where they sell watches on the street. So if you find one, you can have a COSS watch. Yes, what is the COSS staff? When I talk to people, this is what they usually tell me what they believe. You have lots of people hacking away on computers and analyzing data. This was last week's team meeting. One of our data managers was sick, so we have one more. So we have 2 data managers, one physician scientist and a part-time secretary, and myself, who are doing the work. Unless we have people come in who want to write a publication and go through data with us. Yeah, so what do we see? I think we have, or in conclusion, what are our conclusions and current challenges? We do have a strong interdisciplinary group. We have an established infrastructure, and our consultation and our registry are somewhat, or they're ongoing. We have no project at the moment for project-based funding, so no new large trial. And which means we are understaffed, as you saw, even to write new grant applications. We don't have people who have time to write new grant applications along with their daily work or a protocol. That would be a big challenge. The COSS registry has been running into problems recently, and that's data protection. Our ethics committee tells us we should not work the way we work, because what we do is we get lots and lots of information because people want our advice. we use that information, for example, the surgical reports, the radiology reports, to feed it into our database, and they don't want us to do it that way. And of course, we need good questions to convince the funders. We need a clinical trial, which will be a huge effort, so let's do it. If you want to learn everything else there is about osteosarcoma and bone sarcoma in general, you should come to Prague on May 23 and 24, because there we will have as part of the SIOP meeting 2019, we'll have the 5th European Bone Sarcoma Networking meeting, which Jeremy and I are co-organizing. So if you have anything important to say, you should get in touch. If you just want to listen, you can just register here. So thank you.